repair and how are we getting to a complete endovascular repair. So we all know that the open surgery for the aortic arch is the standard, will remain the standard for a long time. However, we also know that not every patient is suitable for this kind of repair, either because they're too old, they're not fit, or they have had multiple prior sternotomies, which makes a reoperation not a very friendly environment. And the endovascular options that we have are multiple, and one has to, of course, differentiate between the distal arch and the proximal arch, because there are two different animals. For the distal arch, the most common devices that we have been using are the single retrograde branch and the fenestrated devices, while chimneys and in-situ fenestrations are more bailout solutions. There is a main difference and a restriction with respect to the retrograde branch, that you still need a landing zone between the left carotid artery and the left subclavian, which doesn't really come handy very often, and therefore the solution of a fenestration with a scallop is quite often much more convenient. There is now also the option as a CMD device to get a retrograde scallop and a retrograde branch and a scallop for the left carotid artery. However, that reduces a little bit the seal zone proximally, and the long-term results of this device need to be awaited. The fenestrated devices are available from different companies. You know probably the Nahuta graft, the Terumo, and the Cook arch device, which has the longer experience. The advantages of a fenestrated device for the distal arch is that it's quite a short procedure if it works out fine, either for the left subclavian or with carotid subclavian bypass for the left carotid. You don't have to go into the ventricle. You don't have to deal with the ascending aorta, even if it's dilated. So it's quite a straightforward procedure. The most experience exists, as I previously said, with the Cook device, and we recently published the results of a multi-center study with 108 patients. It had a very high technical success, although there were some technical issues which were overcome. 30-day mortality was 4%. There were 2 retrograde type IA dissections, both of them in patients with type B dissection, so there should be caution in using these devices in this setting of patients, but still a not irrelevant stroke rate with 7%, although 5% major. The GORD TBE is the device that is used in the USA. As I said, it has some limitations with regard to the distance between the left carotid and the left subclavian, and it also has some limitations with regard to type 1A endoleaks, at least in the first postoperative days. So the most challenging area, however, for the endovascular repair of the arch is when you have to go into zone 0. And again, here chimneys and in-situ fenestrations are bailout procedures, and the branch endografts are definitely the way to go. And we have from different companies different available endografts, which are either single branch, double branch, and now also triple branch. I will go through a few of the endografts that are available here with the Artivion. Nexus is CE marked in Europe now. It has a single branch for the brachiocephalic trunk. It runs through with 2 components, one that is which is implanted over a through and through wire to the brachiocephalic, and then you have to add a component for the ascending. The results were not that bad, with a 7% 30-day mortality, stroke rate of 4%. However, these results do not really include the debranchic procedures that have to be done up front, and we all know they are not coming with zero morbidity and mortality. However, the trend is obviously to a complete endovascular repair and going more and more into complete endovascular to connect all the vessels, the supraortic vessels, by endovascular means. Terumo came up also with a double arch device, now recently also with a triple arch device. And the results in the first study that they published were acceptable, but a relatively high mortality and a stroke rate. The reasons are unclear, but it was also the first experience with this endograft. The most extensive experience worldwide exists with the Cook device, which comes as a double branch device, as CMD, so custom made, patient specific, but also a triple arch device. And we published the first experience back in my time in Hamburg with 54 patients back then, now more than 150 patients experience, with very good results in terms of mortality and stroke rate. However, of course, also selected patients. The following experience that was also published, especially in the subgroup of patients that have an ascending open repair, was very good. So I was very excited about the discussion today, also in the early session of our TV on how we have to deal with this patient, what to do in the acute phase. It seems to be the case that the secondary arch endovascular repair is a very good solution. So perhaps it's not a very bad option to first deal with the patient with a hemiarch and then leave it up for a difficult patient or a sick patient for a later endo repair after all. This is how the triple arch branch device looks like. It has two antegrade branches for the innominate and the left carotid artery, one retrograde branch for the left subclavian artery, and you can appreciate that also there is a preloaded catheter that goes through the third branch over the wire, and you can actually put this catheter back into the second branch, and you will see further on why this could be very interesting. This is a reconstruction of a patient of ours that we treated, and you can see that it actually looks quite satisfactory. There has not been a huge experience with the triple arch device. The results of about 40 patients for different centers were published 2 years ago. With 40 patients, 100% technical mortality, 5% mortality, 100% technical success, 5% mortality, and 5% stroke rate. Of course, the thing with these patients is that you don't stop with the endovascular repair of the arch. You have to move further with the endovascular repair of the thoracoabdominal aorta, and this is something that we also demonstrated is feasible to do a complete full metal jacket in these patients with still total mortality on both procedures and spinal cord ischemia that is acceptable. What about suitability? Does that now mean that all the previous sessions were not necessary and it was the right time for Professor Coselli to go to slow down? I don't think so. This is a feasibility study that we did in our center using the patients, the all-comers that came for open aortic procedures over the last 10 years. And we saw that actually it's less than 50% feasibility according to the IFU criteria for the endovascular repair of the arch, also with the different devices. The European Society of Cardiovascular Surgery and the European Society of Vascular Surgery found a good consensus a few years ago in terms of which patients should be treated with which technique. And it was also obvious that there were some limitations in the endovascular repair. Patients with connective tissue disorder should not be treated with this technique. When you have a very dilated ascending aorta, access vessels difficult, and of course when you have a previous mechanical aortic valve. Let's see how we deal with this limitation. So the proximal landing zone is an issue. Also the patients with residual type A dissection, of course, are frequent patients that we need to deal with. Not all surgeons are as experienced as the surgeons in this room, and we often get requests from other institutions where they just don't want to go back and they don't want to operate again in these patients. So these are some limitations, and you can see here how this limitation get overcome over time. This is a Marfan patient. She already had 2 sternotomies. He had an open repair of the thoracoabdominal aorta, and she was not keen on getting reoperated. Our cardiac surgeon, who is a very good cardiac surgeon, who we work very close with, was not keen in operating her, but we had the issue of the mechanical aortic valve. So when cardiac and vascular surgeons come together, nice things happen, and we were able to, after the whole myth of you cannot pass the mechanical aortic valve was there, I wouldn't do it by myself, but he told me, why don't you try it? So we experimented a little bit how we could do it, and we decided that in the B leaflet valve, you should not, of course, go through the middle, but you can go through the side of the valve, and you can still have some function of the valve. But if you, of course, go through mechanical valve through the two leaflets and you push, then you are sure to destroy the valve. But having that information and with a special custom-made short tip device that Cook Medical provided, we were able to kind of go with a wire through the mechanical valve, bring the tip of the catheter a little bit through the valve, and therefore succeeding going all the way 20 millimeters from the mechanical aortic valve and deploy our stent graft right where we should, and therefore complete the repair successfully. Connective tissue disorders, if you have a good dacron landing zone proximally, and you can also do some debranching to improve the distal landing zone, for example, in the supraaortic vessels, then it's not completely excluded that you can also do that in this kind of patients. The proximal landing zone is, of course, always an issue, and we saw some nice slides in previous talks. The kink is something that really could be difficult on the long term. But if you have such a nice, long, straight tube after a first repair, then it's quite sure that you can do also a secondary nice endovascular repair. This is very interesting for patients with residual type A dissections, where you can proceed and do the whole thoraco-abdominal repair, as we previously said. Even this complete turnout distal anastomosis, even if you have a small thin part of a dacron graft that is still there, you can move on and do the repair. And in this case, we were able to reconstruct this with an arch branch device, and you can see that the result was quite satisfactory at the end. These cases are not so welcoming, and it's very difficult to predict how they're going to straighten or not after you put in an endovascular graft. In this case, we did decide to move forward, and it worked out fine, but these kinks are the biggest enemy of endovascular surgery, and we know that these are very high-risk patients for a type 1A endoleak. Another issue is the distance, and if you always have the distance between the coronaries and the left carotid artery, even this issue has been overcome, because now we have learned from different studies and also from your experience, Professor Evgenio showed previously how also upgoing branches or even retrograde branches have a good patency. In this case, this patient got an antegrade innominate branch, but two retrograde branches also for the left carotid artery, and we reconstructed this patient also with another CMT device. This is how the deployment looks like. We do everything under Move It, and I will show you later what that is. It's our alternative to rapid pacing. And we have changed a little bit our practice. We saw in our experience that exposing the supraaortic vessels to do the access from above did have some limitations with hematomas, with also nerve injuries. So we have now changed to a transaxillary branch to branch to branch through and through wire, which we do. Through that, we bring a 12 French sheath through the right axillary into the ascending aorta. We loop that, and then we cannulate the left carotid artery over that axis. And this is pretty much how it looks like. You are through the third branch, into the second branch, and into the ascending aorta in the graft. You snare a wire that is coming from the right axillary artery, and then you advance your sheath, as you will probably see right away, and therefore you are able to do the rest of the cannulation from the antegrade approach in the arch, and I will spare the rest of the video for you. Tortuous access is an issue. This is also a very big enemy of endovascular surgery. Again, in this patient, we got stuck somewhere in the ascending aorta. We could not move in the proximal descending aorta. We're not able to advance the stent anymore. So together with our cardiac surgeons, we do all of these cases together on the table. Cardiac surgery and vascular surgery. We established the transapical through and through wire, transapical femoral through and through wire, and we were able to advance the graft all the way into the ascending aorta through the previous bio valve of these patients and complete the repair, as you can see here. Also, in the terms of emergency setting, there's quite a few things that you can do, even if this is a custom-made device. The configuration of these endografts is quite simple. Actually, they have 2 or 3 diameters of the proximal stent. They have 2 lengths of the proximal stent. Everything else is the same. So you can use them actually as off-the-shelf device, and I do hope that they will be available soon as off-the-shelf devices. This is an example of a patient who had a previous chronic A dissection. I think it was wrapped somewhere in another institution. Anyway, he presented now with a rupture of his descending aorta and an 8 centimeter ascending aneurysm. Arch aneurysm, a difficult situation to manage even with a frozen elephant trunk. We discussed this case and we decided to go for an endovascular approach. And what we did is take the graft from another patient. We implanted it, but it was not perfect for this patient, so we had to do some modifications in the approach. So we did a ballerina of the supraortic branches with the branch for the left subclavian artery going into the carotid, and for the left carotid into the second branch. And at the end, we also do the candy plaque in the false lumen to occlude the backflow into the rupture. And the patient is now more than 2 years actually out, and he's doing very well. And he's now getting planned to extend more distally with a 55 to 60 millimeters thoracal. You can also work, of course, with physician modified in emergencies. There's a patient where we had no graft in place. We did a surgery modification for the left carotid artery for a non-A, non-B dissection with malperfusion in the visceral vessel, and we were able to orientate that properly. That's the most difficult part when you don't have a CMD device with all the nice characteristics. This worked out fine in this case, and we were able to deal with this patient. This is another option where we had a patient that would have been with a rupture and would have been suitable for an arch branch device if he didn't have an aortocoronary bypass in the mid-ascending aorta. In this case, again, we had to change a little bit our approach. We did a physician-modified fenestration for the innominate, and then we did an in situ laser fenestration for the left carotid artery, using also a steerable sheath, and the patient was released at home. Type A dissections are, of course, something that it's not the place for endovascular surgery, not now, and I think not in the next 10 years. But in some exotic situations, such as in this patient, 80 years old plus in the COVID pandemic, she was with severe pulmonary disease. We used an arch branch device. We were able to kind of seal with the help of a few coils, as you can see, and the patient survived the month. She died, unfortunately, of COPD, of her COPD a month later, but she actually did not die from her type A dissection. So endovascular options, yes, there are quite a few things what we can do right now. We can definitely not deal with the ascending repair, and that was the most common reason why these patients were turned down for endovascular repair also in our feasibility study. I think that's something we need to look into. And finishing the endovascular approach, I would just want to present you our Move It maneuver, the Munich Valsalva implantation technique, which is how we reduce the cardiac output in our center now. We stopped doing rapid pacing and stopped doing vena cava inferior balloon occlusion because they're more invasive, and what we actually do is what the good God has provided as an option, and also the anesthesiologists. and that is to reduce the cardiac output by increasing the PEEP of the patient. So patient goes into manual ventilation. We increase therefore the intrathoracic pressure that reduces the backflow into the right heart, and therefore also the cardiac outflow. And with this, we can very nicely implant these grafts. We have done more than 40 right now with very nice reduction in systolic pressure in all of our cases. However, I want to make clear that endovascular aortic repair is not the holy grail. It's not gonna, for sure, not gonna replace open surgery, and it has a lot of limitations still. Access issues and inability to navigate through the thoracoabdominal aorta is a big enemy. Calcified supraortic vessels, shaggy aorta, are definitely a no-go for endovascular surgery with all the manipulation that we need to do in this area. And small ventricles was a bad experience that I had to make, especially in patients that had premier chemotherapy or radiation. This was a patient that I treated, and one of the most unpleasant experiences where we went in. We didn't really measure much of the ventricle. It's also difficult to do so. But we were almost done with the case when the cardiac surgeon, when the anesthesiologist told us this is getting hemodynamically unstable. We had actually perforated the left ventricle in this case, and the patient eventually died because we were not able to stop the bleeding. So definitely a few things where we need to be more cautious, but I think that to summarize, the endovascular repair is a good alternative right now for high-risk patients. A lot of technical limitations are getting eliminated. Middle-risk patients, we need to wait and see how they're going to evolve, and we need some good studies to really evaluate it on the long term. But of course, the future is going to be more endovascular, and with this, I would like to thank you for your attention. And nice there is a workshop tomorrow on this endovascular complete arch repair. So if anybody's interested, tomorrow 7:30, there will be some breakfast, perhaps.
Any questions from the audience for Nikos?
In the future, because when we look at the results, mortality is ranging between 3 and 5, stroke rate between 5 and more than 10. This is something that we have in type A dissection. So do you think in the future you will be able to reduce this complication rate and address also lower risk patients?
So I think the perspective is that we will have to find the golden middle way, and that we will have to be a little bit more differentiated in how we decide. I think right now in some centers there's a big trend for endovascular surgery. In some centers is still a big competence in open surgery. Unfortunately, I have to say that my feeling is in cardiothoracic that less and less surgeons can do the complex cases. And I see from a lot of smaller centers, they send us patients and I tell them, why don't you do it open? And we discuss it with our cardiac surgeon, and we don't understand why this patient should be done endovascularly. But it seems to be very big reluctance. I think that we're going to reduce furthermore the stroke rates in endo. I think that we will be able, through good selection and improvements in technical aspects, be able to offer more, but it's not always going to be the best solution for the patient. So I think that we need to work very closely together to see which patients need to get which treatment. And that is important to do always in aortic boards and in interdisciplinary discussions.